Hello and welcome you all back to the CRISP TV. Today is 10th October and it's the first day of the CRISP 2025 conference. We are almost running in the evening and night hours now. I am your host at the CRISP TV. My name is Dr. Abad Khan. I am an interventional cardiologist currently practicing at St. Joseph Hospital, Ghaziabad. Now we have our new guest, Dr. Jaspal Arneja. He is with us and he'll be sharing his insightful thoughts with us. Dr. Arneja is a visionary, highly knowledgeable and a skilled operator himself. Already has headed multiple and chaired multiple top-tier societies in cardiology. Sir, welcome back to the CRISP
Thank
TV.
you so much. It's a pleasure being here again. It's a wonderful meeting that's going on.
Yeah. Sir, since last time also we had a discussion on the calcium modification treatment and devices.
I really forgot about it.
It's fine, sir. This has been the norm of the day and the talk of the town. And what do you think has changed in the past 1 year? The percentage use of each devices, the use of rotablator, the use of orbital atherectomy, the use of lithotripsy devices. In your practice, and how commonly are you seeing that the use of synergistic devices now for calcium management, sir?
Basically, calcium management still remains one of the most difficult task of a interventional cardiologist. It's not only consumes a lot of time, takes a lot of devices. It's quite intensive. So what has changed in the last 1 year? I wouldn't say not that devices or technology has changed. Our understanding is constantly improving, and we are now trying to use as less devices as possible. Rather than using 3-4 devices, I would like to assess with imaging what device will do the best job in it. So what we have seen an increase as a single device in various calcium lesions is the use of orbital atherectomy. If you want to have a single device, then somehow orbital atherectomy is taking a higher scope. But obviously you choose your devices based on the calcium morphology and then take a call. Sometimes if it is a concentric calcium, 360 degrees, sometimes, where a very high pressure balloon, an OPN can do the job, with safety. But when you talk of calcium, we talk of high pressures, so we talk of safety. Here again, just OPNC would do the job which any other atherectomy or IVL would do. But then you have to choose that, it has to be concentric calcium for an OPN. And so yes, I think it's exciting. What has changed is our understanding, and we try to use, obviously sometimes you need to have in uncrossable lesions, you have to combine devices, synergism, you do the rotablation and then do IVL. So yes, it's case dependent, but in the end, with imaging we do get an idea what is going to be the best device, and in the end it is whether you use one device or 2 or 3, it's the areas which matter for a good long-term prognosis.
Perfectly put, sir. Actually, it's maybe not always the best or the newest technology which is helping. It may be the understanding of the already proven technology. We have a better understanding and we may be able to offer better results to our patients if we have a better understanding of the devices and of the disease pathology itself. So, why to guess when we have an imaging catheter in the lab and use those, and we may be able to pull off maybe using lesser devices for the patients. Also, sir, if I am a beginner, if I was to ask, okay, we have a patient who has an in-stent restenosis. So now, as I see it, there are only 3 possibilities for that. There might be an underexpansion which has caused this restenosis. There might be an undersized stent which has caused this restenosis, or there is a neoatherosclerosis or a neointermental hyperplasia which has caused this restenosis. And I know the treatment for all of that. For an eye, so I can use a cutting balloon, a larger non-pressure, non-compliant balloon for higher pressures, and maybe for neoatherosclerosis, maybe a stent again, maybe a 0.25 size larger stent. In all of this, why do I need imaging for this if I ask as a beginner? How do you convince me with the facts?
No, there is imaging in, your stent has failed once. Yeah. So you don't want to have to fail again after a second intervention. So I think whatever has gone wrong in the previous plasty has to be seen, identified, new mechanisms that have happened. If it's not the previous stent, it was not under expansion, it was the right size stent, then you need to know whether it is neoatherosclerosis or or it is neointerventional hyperplasia, because here again the treatment modality might change. So I think imaging, although there is no study, prospective study in ISR, but it's a complex lesion, and EC guidelines say that the role of imaging is class 1 in all complex lesions, and ISR is definitely a complex lesion. So I would go with imaging, still with imaging, to see and correct and see whether that's underexpanded stent could be because of some calcium behind. So unless you see, you will not use an IVL behind to see what is there behind the stent. So I think imaging will be required to perfectly sort of correct malposition, undersize it to make it proper sized. Although if you don't have, you will do it. I'm sure you use a 0.5 higher balloon to post dilate and do whatever. Like again, the tissue growth, as you said. Now, if it is within the first 1 year, it is likely to be neointerventional hyperplasia. Beyond 1 year, it could be neotherosclerosis. And neotherosclerosis, if it happens, can again be severely calcified inside the stent. It could be even a lipid plaque, a vulnerable plaque, or a thrombus if it's an ACS. So I think seeing the type of whether it's hyperplasia or neointerventional atherosclerosis, like in NIH, a DCB, once you have got good, would be the right answer. But if it is predominantly neoatherosclerosis, a vulnerable plaque, lipid, here I would put another stent possibly. So imaging is going to help us in ISR, and I would be very hesitant do an ISR without imaging.
Absolutely, there is no rationale of performing these complex procedure without knowing what you are dealing with. If it is an ISR, then you have to treat it, and you can only succeed if you have to abolish your last failures. So very well put, sir. This is the answer. There is no rationale of performing angioplasties for ISR patients without imaging, actually, sir. And this has been the hot topic of the day. Is DCB really the future? Is it going or just going to fade away and be as a synergistic device for small vessels and side branches in the future? How do you see it, sir?
No, I think DCB is an evolving branch, it's an evolving technique, and it is going to stay. The reason being, we have seen that the stents are going to be the norm, they are the norm now. But we know long stents, there is an event rate with a stent. Previously we thought if your stent does well for 1 year, it does well. But now we know that every year, beyond the first year, there is a 2% chance of stent failure with neotherosclerosis. So maybe 7, 8, 10 years down the line, if you have 2, 3 stents, this becomes very high. More than 50% are going to have an event. So our aim today is to limit metals, obviously long disease, bifurcations. So DCB is going to stay. The DCB technology is evolving. The way we are doing DCB is evolving, and less metal is the future. So I firmly believe DCB is going to stay, is to come bigger.
Absolutely, absolutely. The idea behind going off for all these technologies and using this as devices in a phase is to be bettering those things which are not working well. Long stents are not working well, diffuse vessel stents are not working. So we have to change the technology and change the maybe optimal management for those patients. As rightly sir said, maybe DCB will remain the future for these kind of scenarios. Also, sir, as a course director, how happy and proud do you feel to achieve this kind of success? This CRISP 2025 is being seen as compared to last year, for that matter, as a general conference.
I'm absolutely delighted to be part of this beautiful meeting, CRISP. And I see a real, 24 was an amazing success, the inaugural meet. And it has, so rapidly built up into, within 1 year, into a meeting which was talked about so much. It is, not only talked about, but for any successful meeting, it is the content that is going to drive people in. So I think very well thought of content. Most important, lot of time for discussion. I think we were discussing for more than 30 minutes on,
Drug-coated balloons.
On drug-coated balloons and on physiology. More than 30 minutes we were discussing. So and about 50, 100 questions, answers being, discussed in a session. That's amazing. I'm really, really delighted, and it's Ankur, Rahul, and all of us have really, really delighted to be part of it.
Absolutely, sir. We all hope that 2026 CRISP turns out to be even bigger and better than what we are already having, sir.
I'm sure it is going to be.
Thank you. Thank you. And we'll finish the day the first on CRISP TV, and see you tomorrow on 11th of October. Thank you.
Thank you.
Sir, photographs.
Yeah.